Good morning. I'm Dr. Geraldine Zamora, and I am both honored and it's my pleasure and honor to introduce today's Diamond Jubilee Professorial Chair Lecturer. She is a distinguished clinician and academician who had her training in internal medicine, rheumatology, and clinical epidemiology in the UP Manila PGH, and is currently serving as a professor in the UP College of Medicine. She has held pivotal roles in various medical institutions, including being chief of the Division of Rheumatology here in the Philippine General Hospital. Our speaker is an accomplished researcher with local and international publications, booklets, and books on lupus, rheumatoid arthritis, osteoarthritis, gout, and related topics, and has contributed significantly to patient advocacy. Her leadership in organizations, including her tenure as president of the Philippine Rheumatology Association, underscores her commitment to advancing medical practice and education in the field. Today, she will share insights from her extensive experience in rheumatology, emphasizing the importance of the impact of lupus low disease state. Please let us be taught by Professor Evelyn Salido. Thank you, Jean. Can you hear me? Thank you for your kind introduction. And good morning to everyone. So let me begin uh, by saying my thanks. First of all, to Dr. John Añonuevo, to Dean Charlotte Chong, Chancellor T and Vice Chancellor Reyes for nominating and approving this professorial chair grant. To the Division of Rheumatology for supporting me since I was a fellow and up to now as the chief of the division, especially to our fellows now, Dr. Mulies, who helped me with the presentation. And most of all, Professor Emeritus Clemente Amante and Professor Esther Penserga, our mentors in the Division of Rheumatology, who taught us to always look for the right thing to do. But they also taught a few things like cramming for a professorial chair and finishing 30 minutes before. So I'm giving my thanks because for me, a professorial chair lecture is always a time to reflect, and it's time to discover new things. Also, a time to display what we have been doing. So for this lecture, I'd like to share with you the definition of the lupus low disease activity state as an outcome in our clinical practice and not only in research. I'd also like to share with you the association of the lupus low disease activity state and health outcomes, in particular damage and flares, as well as quality of life, and strategies to achieve the lupus low disease activity state. Kinakabahan talaga ako, nakalimutan ko, may virtual audience nga pala tayo, no? Thank you to our virtual audience. I know some of the alumni of the rheumatology training in PGH are also watching. So good morning to you too. So let me begin the lecture by talking about lupus. So in a nutshell, this is what we should remember about lupus.
First, it's an autoimmune disease, and we have, through the years, we know more about its autoimmune nature. Secondly, it's also inflammatory. So, what do you know about inflammation? If inflammation persists, it leads to damage. Okay, so we should control inflammation. In Asia, its prevalence is 30 to 50 per 100,000. So that's from a systematic review in 2010. But up to now, this is still one of the most commonly quoted prevalence figure. I also recently saw an article saying that the prevalence in Asia is 4.5 to 45 per 100,000. In contrast, in the US, it's 20 to 150. So mas malaki yung range nila. That's out of 100,000. So that's last year. And thirdly, lupus is present up to 9 times in reproductive aged women. So kahit siguro natutulog tayo, no, alam natin to, it's very common among women. And I did some computations. So there are 58 million Filipina in the 2024 census. And if 35 million of them are in the 15 to 64 age group, then approximately we have 18,000 people women with SLE in the Philippines this year. Parang konti, no? 18,000. But let's look at cancer. So this is 2022 data. And Filipinas, no, women with cancer, total 105,000. And if you look at the most common, that's breast cancer, that's 33,000 cases of breast cancer. So if you compare that to lupus, which is 18,000, which is 50% of breast cancer. So I hope that that makes the figures more palpable to us. It is a big problem. And etiology is multifactorial. Kaya rin siguro mahirap siya, no? Because genetic, immunologic, hormonal, and environmental factors are at work. And for any particular patient, we don't know if it's just one etiology or several etiologies are working. Most importantly, lupus is a very heterogeneous disease. So it can be mild, sometimes even asymptomatic. And but it can also be very severe. The worst being those with renal and cardiovascular involvement. It is also multisystemic. So we see most commonly affecting the skin, the musculoskeletal system, the joints, hematologic, CNS, and down the line. But it also affects blood vessels. So blood vessels are anywhere in the body, and therefore lupus can affect virtually everywhere in our body. And over the years, there has been improved mortality and morbidity because we are now able to diagnose it early and treat it, but it's still increased. So yun ha, what do we remember? It's autoimmune, it's inflammatory, it's heterogeneous, and it's multisystemic. And it's common in Filipinos. So what are the treatment issues that we encounter? So you first look at the middle part of this diagram. So you see here 4 parts of, these are 4 treatment issues that we have observed, okay? So the first one will be persistence of disease activity, accrual of organ damage, as well as the presence of comorbidity. And these are because we have limited target therapies. Patients also do not adhere perfectly to their treatment regimens. And unfortunately, many patients still do not have access to quality care. We see patients in PGH who have been bounced back from one physician to another, with various diagnoses. Sometimes the diagnosis is correct, they're able to pinpoint that it's lupus, but the management is not optimal. Okay, and they reach us a year or 2 years later. Another treatment issue is occurrence of poor quality of life. And you might think that this is an effect of persistent disease or madaming organ damage or comorbidities. But on top of this, there are refractory symptoms which may not be associated with disease activity, damage, or comorbidity. And some of these are fatigue, anxiety, depression, and even pain, like fibromyalgia. On one hand, there are also physician-related treatment issues such as clinical practice variation and delayed immunosuppression and targeted therapy. Fortunately, we have newer drugs like anifrolumab, for example. Belimumab has been in the market for more than 10 years. Anifrolumab uh, this year. So these are newer drugs that are targeted, no? So anifrolumab is an interferon drug, no? It's an anti-interferon drug. But unfortunately, these are very costly drugs. And even the old drugs that we have, like azathioprine, mycophenolate, and cyclosporine, are also quite costly. Like, for example, mycophenolate, that's around 300 pesos per day, and you have to take it continuously. We also need to tackle the benefit risk balance of glucocorticoids. So we want to benefit from the anti-inflammatory effect and immunosuppressive effect of glucocorticoids. And we want that to work fast, no? So we want to take advantage of that, but we have to balance it with the long-term adverse effects like osteoporosis, cardiovascular disease, diabetes, and infections. Also, because lupus is a multi-systemic disease, there are many organs involved, and there are new drugs, there's new knowledge evolving, then there is a lot of uncertainty in our treatment protocols. So I guess that's also one reason why listening to this lecture is important, because we will be talking about strategies on how to control lupus. Okay, so let me talk a little bit about damage. This slide is from a cohort in Sweden. So Dr. Frodlund in 2020 wrote a book, and her examples are mostly naturally about lupus in Sweden. So let's see if they're very similar to what we have in the Philippines. Okay, so this graph is showing us disease onset. So so this shows us that talagang during the reproductive age group, no? So that's 20 up to 39. That's the bulk of patients with lupus. But very striking is that you also see it happening even after 40, and some even 80 to 89 years old, no? So habang tumatagal na ang buhay natin, no? We're more successful in increasing survival. We also have patients who live longer and then they're already old and they still have lupus. Like, for example, I had a patient who was 50 years old when she had lupus onset, and I was taking care of her for 25 years. And last year I lost her to diabetes and infection. So that's at 75 years old. Okay, but another striking thing about this graph is that you see it even below 19 years old. So meron ng 0 to 9 and 10 to 19 years old. So if you imagine a person who has onset of lupus at 12 years old has a lot to go through. So let's be empathetic. Okay. What about lupus and organ damage? Siguro hawakan ko na lang. Is this better? Okay. So lupus and organ damage. So we see here SDI points at the horizontal axis. So the more points, the more damage. And this is in more than 500 patients. And the important thing to know about this graph is that 59% had a damage score of 1 or more, okay? And about 25% had a damage score of 3 or more. And the third point is that damage, it adds up from the time of disease onset as you get older. And that is shown very nicely in this graph. Also, if we look at the different organs that can develop damage, this is years to organ damage. I'd like to point out that very early on, we may see diabetes, damage on the skin, peripheral vascular disease, even cardiovascular, pulmonary, and renal, and even neuropsychiatric. In neuropsychiatric, that's mostly cognitive impairment, no? So you might have a person 30 years old with lupus with cognitive impairment. Can you imagine how difficult that would be, no? Mahirap silang kausap, mahirap ipaliwanag yung gamot, no? And it will be very difficult for them to be employed because of that cognitive impairment. So those are the damage that can occur early on. But look at malignancy. It becomes a damage after 10 years. So it's something that we also need to watch out for among our patients. And ito yung distribution of organ damage in the different organs. So pinakamataas yung neuropsychiatric. And I was mentioning that that's mostly cognitive impairment as well as affect disturbances like depression and anxiety. And looking at death, so in 54 patients who died and they looked at the death certificate, the number one cause of death among their patients was malignancy, second was infection, and third was cardiovascular disease. So when we see a patient newly diagnosed with lupus, we worry about the disease activity. But over the years, once we have controlled disease activity, then we worry about their having infections, we worry about cardiovascular disease, and also development of malignancy. So does this happen in Filipinos? Yon, kailangan pa nating pag-aralan ng mabuti yon. And we're hoping that in 1 to 2 years, we'll have more solid data to show. Okay, so, thank you. So let me tell you about this small study that we did in 2018 to 2019. So we collected data from a review of medical records. So this is Philippine General Hospital, and this was published this year. So we had 44 newly diagnosed patients with SLE, and we looked at their status at disease diagnosis 6 months later and 12 months later. So our patients were mostly young. As you know, the mean age was 29 years old. So they're 29 years old, 50% of them were inpatients and 50% were outpatients. And there was a delay of 6 months from occurrence of symptoms to diagnosis. And most of their manifestations were in the skin and hematologic and musculoskeletal, 61%, and renal in almost 50%. The initial therapy given were mostly moderate to high dose steroids, as well as almost everyone had hydroxychloroquine. So that's an improvement. And those with nephritis were also given, in addition, IV cyclophosphamide, azathioprine, mycophenolate mofetil, and one patient was given rituximab. One noteworthy observation is that fewer patients with lupus nephritis received IV cyclophosphamide during the first 6 months. So this is really a delay in administration of immunosuppression. So let's look at the outcomes in this small cohort. There were 36 hospitalizations during the there were 36 hospitalizations over 1 year, and 34 of them were during the first month of diagnosis. And there were 7 patients who had more than one hospitalization. We had 20% 30-day readmissions. And looking at the other outcomes, which is the modified low disease activity state. Bakit siya modified? Because instead of using the SLEDAI, which I will show you later, we use the MEX SLEDAI, which does not have the serum C3 and the anti-dsDNA, which, as you know, are costly laboratory tests. So we looked at the modified lupus low disease activity state at 6 months, and that was 34%. But look, there was one patient out of the 42 who had organ damage during the first 6 months. So that's already permanent. It's something that she will carry on throughout her life. And we had 4 deaths during those first 6 months. That's 10%, 4 out of 42 patients. What about at 1 year? Okay ba sila at 1 year? 68% achieved the modified low disease activity state, but there were 7, so additional 6 who developed organ damage, and there was only 1 patient who was in remission. Only 1 of the 42 patients was in remission. Unfortunately, yung pasyente na yon also had a lot of organ damage. So maybe poor quality of life then, no? Okay. So our conclusion from these studies that there was a very low rate of remission. The lupus low disease activity state, which was a modified score, was achieved in 68% of patients. Maybe the percent would be lower if we use the SLEDAI, no? Because many may have low C3 and positive anti-dsDNA, and they may not have symptoms. So there was organ damage in 16% of patients. There was a high hospitalization rate in this cohort of newly diagnosed lupus observed over 1 year. So we should do better. That's the conclusion. No? Now let's look at our census now. How are we doing now? So this is January to June. And again, I thank ANSES for this. So these are inpatients. We had 215 referrals, and 173 of them were rheumatic diseases. So yung iba, non-rheumatic diseases. And 73 of them were lupus. So that's 42% of our inpatient referrals were lupus. And most of them were follow-up patients. 24 were new. No? So we had 24 new lupus patients in 6 months. And look at the mortality. 14%, 15% overall in all our inpatients, 12.3% in our lupus patients, mas mataas in our new patients. So we should really do better for our newly diagnosed patients. Maybe there's higher mortality because delayed and diagnosis. Then they come in very sick now, may infection. We cannot give our immunosuppressants right away. Okay, and look, compare that with our wards, that's 9.5. So parang yung mortality ng lupus is like the ER mortality, 11%. So they're really difficult to manage. Yung mga new patients natin, pang ICU sila, no? Yung mortality nila katulad ng ICU. So let's look at duration of hospitalization. So overall, we had 16 days for those who were able to go home and 10 days for those who died. And among lupus, 16.2 days, and those who died, 6.4. So this is where we are now. Again, more work to be done. So hindi lang kami to, no? Kasali yung buong department. So let me just go back several years ago in 2018 when I also had a lecture on lupus. So I was talking about mortality data for lupus in PGH. So we had a study 1974 to 93 which included inpatients. So noon, 14% yung cumulative mortality and 40% was because of lupus activity. For the next 10 years, 10% yung mortality, 83% from infection and lupus. And that year, when I had the lecture, the mortality was 17% among the inpatients and 53% due to infection, and 50% of them were hospital-acquired infection. And ito yung mortality rates at that time. Parang better na yon, no? In terms of the MICO admission, but for the ward, it's almost the same. Okay, so looking at our patients with lupus who died, the immediate causes were shock, fatal arrhythmia, and acute respiratory failure. Okay, so this is my reflection. So we must achieve earlier diagnosis, deliver optimal treatment during the first hospitalization, and we must try our best to give early and persistent immunosuppressive treatment for nephritis and maybe for myocarditis. Kasi yung myocarditis, when it's not treated very well early on, it becomes a cardiomyopathy later, and they become chronic heart failure patients. Okay. So we must also know our patient's profile better. We must operationally define our desired outcomes and observe our patient's scores to see what really works. No, yung nasa clinical trial, we want to see if it works in our practice. Okay, so that's my segue into the Asia Pacific Lupus Collaboration. And I'd like to acknowledge Chancellor T, who is now in the room, who has put PGH in the map as a member of the Asia Pacific Lupus Collaboration. So this collaboration was born in 2012. It's a joint venture by all of those countries, and it's a consortium of expert lupus clinicians and researchers from our Asia Pacific region coming together to improve outcomes for patients with SLE. Why is the Asia Pacific region special? Because we have a high frequency and we have more severe lupus patients, which allows us to have this special advantage to better understand lupus. And this allows the APLC to make contributions to a global impact. The APLC has more than 50 investigators from 25 sites across 13 countries. So aside from UST, then University of the Philippines is participating in this collaboration. Okay, so that's my long introduction. Napagod ba kayo listening about lupus? Let's now go to the meat of the matter. So what's LL-DAS? Kailangan paglabas natin, memorize na natin itong 5 criteria. We have to remember these 5 criteria because when we see our patients in the ward and in the OPD, we have to check, meron ba sila nito? Do they have this? Okay. So number 1, SLEDAI 2K less than 4. 4 or less. Okay. So ano ba yung SLEDAI 2K na yan? Papakita ko later. So there should be no activity like hemolytic anemia, GI disturbances, and activity in the major organs, which are the kidneys, the CNS, cardiopulmonary. There must be no fever, and there must be no vasculitis. Number 2, dapat walang bagong disease activity compared to the previous assessment. Okay? And the physician global activity, which is simply the physician's assessment of overall assessment of disease, should be 1 or below. So the PGA, that's a scale from 0 to 3. So 3 yung very, very active and severe lupus. So dapat 0 to 1. Okay? And the prednisone dose should be 7.5 milligrams or below. And if the patient is taking immunosuppressives or biologics, then they are well tolerated at maintenance doses. So paano ba nagawa itong LLDAS or the Lupus Low Disease Activity State criteria definition? So this is the process that occurred, no? So there was consensus among experts. So individually, they suggested definitions, they built up consensus, and then there was validation in a retrospective cohort, and then further validation in a prospective cohort. So valid siya, maganda siyang instrument, no? And later on, I will show you a few studies using this definition to determine the association of this lupus state with other outcomes. So ito yung SLEDAI 2K, which should be 4 or less. Okay. So, ang dami, no? So, we look at various manifestations, and they have very particular definitions. So, if you want to look at this closely, then you just Google it. So, consider the last 30 days when doing the assessment, and if you have more than 4, then active disease yon. Okay. So this is the second of the several studies of the Asia-Pacific lupus collaboration. And this is a relatively early publication in 2016. Okay, so so this is about the frequency and the predictors of the LDAS in the APLC cohort. So look at the right side of the screen, which is the frequency of achievement of the different criteria of the LDAS. And we see here that in this cohort, almost 2,000 patients, 99% met at least one criterion. Kaya lang that's not good enough, di ba? Hindi good enough yung 1. Kailangan 5. So how many met all the 5 criteria? A low 44%. No? So this was 2016. And ano yung pinakamahirap? Pinakamahirap is criteria number 1. That's the most difficult to achieve. And the second was prednisone dose of 7.5 or below. So those were the 2 criteria which were most difficult to achieve. Okay. So again, looking at this cohort, this was a group of patients with a mean disease duration at recruitment of 9 years. And observations on treatment practices in this Asian cohort, Asia-Pacific cohort, is the lower frequency of use of immunosuppressives if you compare it with Australia. No? So maybe it's a problem of access, economy, no, cost. And the second observation is the higher mean daily dose of prednisone or prednisolone, which was 11 milligrams per day, which contributes to significant morbidity. Anong mean steroid dose natin sa OPD? I would bet that it's higher than 11 milligrams per cent. No? So bawasan natin. Let's give other immune modulators aside from steroids. Let's give hydroxychloroquine as well. Okay, so in this study, they looked at predictors which were significantly associated with achievement of LDAS, no? So, ano ibig sabihin na itong table ko? So, if you have a shorter disease duration, then there was a lower likelihood of achieving LDAS. I would think that's logical, no? Kasi bagong diagnose pa lang sila eh. But the presence of discoid rash, renal disease, elevated and the predictor that they identified, which was associated with the increase in likelihood of achieving LDAS, was a higher national social wealth. Unfortunately, ang Pilipinas ay kasama sa lower social wealth, no? Hindi tayo kasama ng Australia, Hong Kong, Singapore, and Taiwan, which were in the group of higher social wealth. Okay, so that's the first part. The second part is association of LDAS with health outcomes. So the health outcomes I'm talking about are damage and flares. So bakit ba tayo interesado sa damage and flares? Paulit-ulit ako today about damage and flares, no? When what our patients really like to achieve are lower mortality and better quality of life. Buti na lang from 1950 to 2000 and now 2024, the 10-year survival rate in patients with SLE has improved. So 63% lang noong 1950, 91% noong 2000. I think ngayon 95% na ang 10-year survival of lupus, no? But still, there's poor quality of life, no? So let's look at how damage and flares impact mortality and quality of life. Okay. So let me introduce you to the second index for this morning. So this is the SLIC ACR damage index. The damage index na lang for short. As you see, hindi biro, no? Because there are a lot of items that you have to check. So we are advising that this be checked every 6 months. And we look at the eyes, eye putol. Neuropsychiatric, we look at the kidneys, pulmonary, and cardiovascular. So again, if you want to look closely at each and every detail, then just look for it online, no? So we also look at peripheral vascular, GI, musculoskeletal, the skin, premature gonadal failure, diabetes, no? Take note, that's a damage among patients with lupus, and malignancy as well. So we get a total score. So ano yung association ng damage and mortality? So this is not part of APLC. This is a systematic review and meta-analysis published, I believe, in 2020. So this is a systematic review of observational studies from 2000 to 2017, and I believe their search was quite thorough because they also looked at citations, they also looked at gray literature. And out of several thousand of studies, they picked 21 quality studies, no? And 14 of them reported damage as a quantitative measure, And these 10 studies, which I'm showing you at the right, I'm sorry, it's blurred. Look at time to event analysis. Important thing to remember is that they looked at the risk of death per unit of the damage index. And if you look at the summary statistic here below, um, what's the hazard ratio of damage and mortality, no? So 1.34. So if you have increasing damage, then you have the higher likelihood of dying. And the confidence interval of that, 95% confidence interval, is 1.24 to 1.44. It's a bit heterogeneous because the I-square is 52%. But if you remove the study of MOC, it becomes 1.44. Trying to show you here. This is another APLC study. So this is a reiteration, no? Because this is now from the Asia Pacific. This is relatively early into the cohort. They had a small population, 191, followed up prospectively on the average for 3.9 years. And very important here is that they looked at patients who had an LLDAS, more than 50% of that observation period. And among those patients, they had less flares, and that's shown here, no? So you have a lower risk of having any flare and a lower risk of having severe flares. And there was also reduced organ damage accrual. They were less likely to have increase in the damage index of one or more. And there's a lower risk of having damage. So that's 0.47 relative risk. Okay. So that's convincing, although maliit lang to na study. Let's look at the bigger one. So this is very recent, published in the Lancet. This is 2024. So this is still from the APLC. They had more than 3,000 patients, almost 3,500. 3,031 were Asians. They were adults with lupus with a median follow-up of 2.8 years. So this is 37,662 patient visits from these time periods. Okay? So they looked at sustained low disease activity state, which was defined as 2 or more consecutive visits over 3 or more months with an LDAS. And 72% of the patients were able to achieve this status at least once. And they looked at irreversible damage as well as the occurrence of flares. So this was a prospective multinational longitudinal cohort study. So I'll be showing you two graphs, which will be about damage-free survival and flare-free survival. So the first one is damage-free survival. Okay. So medyo busy, no? But these are the numbers at risk. And at the y-axis, that's the probability of no damage, no? So probability of no damage, gusto natin 100%. And these are the different duration of observation, I believe. And if you have shorter, that's so those people 0 to less than 3 months with sustained lupus slow disease activity, kung ganun lang, less than 3 months lang sila, then they have a lower probability, so double negative, no? Double negative. They have a lower probability of having no damage. So they have a higher probability of having damage. So hindi maganda if they're only able to achieve sustained LDAS 0 to less than 3 months. So we want our patients to be able to sustain the LDAS more than 36 months kasi ito yung 36 months, no? Okay sila. Now, let's also look at flare-free survival. So those who had more sustained LLDAS also had less chances of flare. Okay. So to summarize, this large study of almost 3,500 patients who were observed over an average of 3 years, and 72% of them were able to sustain LLDAS at least once over 3 months. There was reduction in damage, and any duration of sustained LLDAS or remission more than 3 months. So kahit 3 months lang, that was protective. The hazard ratio was 0.60. Of course, if you have a longer duration of sustained low disease activity state, then that's even better. Remission, 0.66 ang hazard ratio. Parang konti lang yung advantage ng remission. And actually, the last bullet here is saying that sustained remission or steroid-free remission were less attainable than LLDAS. So we should really aim more for LLDAS, okay? Which was able to reduce damage accrual and also reduce the probability of flare. Okay, so this is another study. This is not APLC. But I chose this because these are newly diagnosed patients with lupus. Parang yung study namin kanina, no? So the APLC kasi they had varying duration of disease. But this cohort of 116 newly diagnosed patients in Italy were newly diagnosed. So they looked at, what outcomes did they look at? They looked at the LLDAS and CR is complete remission. So they looked at it at 6 months. So yun yung T1 after treatment, initiation, and over the next 12 months. They also looked at damage after 18 months of follow-up. So dalawang time points lang, no? So T1 is 6 months and then up to 12 months and damage at 18 months, okay? So at 6 months, LLDAS 42%, complete remission 21%. At T2, which was at 18 months of follow-up, LLDAS 46%, complete remission 31%. And they found that early damage among those able to achieve complete remission in T1, the odds of that ay namatay. The odds of that was 0.07, no? And those who achieved LLDAS, so the odds of early damage among those who were able to achieve complete remission at 6 months was very low, 0.07. And the early damage among those who were able to achieve LLDAS at 6 months was acceptable, 0.25. So the message here is that patients who achieved LLDAS at 6 months and maintained it up to 18 months developed significantly less damage. So I hope I convinced you that LL-DAS is a valid target, an alternative to remission in the early stage of lupus management to prevent organ damage. Okay. So let's now look at the association of LDAS with health-related quality of life. So this is an APLC publication in 2017. And they had more than 1,000 patients with a mean age of 31, mean disease duration of 9 years. And there were 124 Filipinos in this cohort of 1,400 patients. There was damage in 35%, and their physician global assessment at enrollment was 0.5. So hindi masyadong active yung disease. And the SLEDAI 2K on the average was 4, and they had this distribution of major disease activity. 25% had renal involvement at recruitment, and the LDAS was achieved by 42%. Okay. So anong nakita nila? So they looked at the SF36. So the SF36 is it's a generic instrument to measure quality of life, and it has 8 domains. So these are the 8 domains which has a scale of 0 to 100. So pag 100, that's better quality of life. And then there are 2 summary scores: physical summary score, mental component summary score. So these 2 summary scores are standardized around a US normal population mean of 50. So normal US population, ang mean nila na summary score ay 50. So anong scores? So general health and vitality had the lowest median scores, 57 and 62 respectively. And they were able to show that there were some factors which were associated with a better quality of life and some factors associated with a lower quality of life. So for better quality of life, being Asian, mas maganda yung quality of life ng Asians compared to the Australians. And higher education led to better quality of life. A shorter disease duration and younger age at diagnosis, and the LLDAS. Okay? So, kailangan talagang ma-achieve natin yon. CB, Asian, panalo na tayo, no? Higher education for some of our patients, and LLDAS, of course. Pero ano yung lower quality of life? Active MSK or cutaneous manifestations, higher SLEDAI score, higher prednisone dose, and the presence of damage. If we think about it, MSK, joint pains, di naman nakakamatay yan. No? Yung rash sa pisngi, hindi naman nakakamatay yan. Or yung alopecia, no? You can function. But these are things which affect the quality of life of our patients with lupus very much. So this is a realization. Sometimes I also catch myself I catch my thoughts. Kasi ang daming mareklamo dahil dun sa kanilang alopecia. Wala naman silang ibang problema except may alopecia. Or masakit yung isang daliri. Gusto ko na lang sabihin, medyo na akong pahirapan. Madami pa akong titignan ng pasyente. No? But, these are things that matter to them very much. So we must pay attention to them. Okay. So what must we do? Ito na yung last part. So I adapted the EULAR, okay? You can see this as a journal, the 2023 EULAR CPG for the management of SLE. Natutunan ko yung ganito sa IM Summit. There was a lecturer who showed a slide very similar to this. Kinaya ko siya. Okay. Di ba mas madaling tandaan? These are the 5 pillars, kumbaga. Multidisciplinary but individualized management. So, corny na to. We hear this every day, but it's true. We have to work together. So, sana nga meron ng autoimmune clinic sa OPD. Maybe in the next 5 years, matutupad yung pangarap na yon. Where patients with autoimmune diseases can just go and there will be different specialties doon, no? Para hindi na naiisipin ng rheumatologist, paano ba ako mag-screen for malignancy? Kasi meron ng oncologist who will help, okay? And shared decisions talaga. Kasi nga, yung mga doktor, ang importante sa atin yung anti-dsDNA na mataas, yung proteinuria na +4. Wala namang pakialam yung pasyente natin doon. Gusto nila mawala yung alopecia. Gusto nila magkaanak sila. No? And they want the pain to go away. Okay? So that's most important. Pero ito kasama. The cost. So tayo resource limited. Kaya very challenging yung cost. We must take into consideration the cost to the patient, and the cost to society of the treatment that we give. Okay? We should monitor. What do we monitor? Disease activity. So fellows, every visit, disease activity. And organ damage at least annually. Better sana every 6 months. And then we shouldn't forget non-pharmacologic interventions, no? Mas mahirap to because there are more that we need to pay attention to. It's really a long list. And some of these we forget, no? The pharmacologic interventions, we must base this on these important considerations: the patient characteristics, the organ involvement, the treatment-related harms, the comorbidities. Baka may TB yung patient, hindi natin mataas yung immunosuppressants, and the risk for damage, as well as patient preferences. The patient might want to have a child next year. So you have to plan when you discontinue methotrexate for that pregnancy. Okay, and we must diagnose early. Nung fellow ako, mahirap pa yung access to serology. But we now have more access to serology. We have the different autoantibodies. We should screen for organ involvement. So kahit walang edema, kahit walang hypertension, we should check the urinalysis because nephritis is silent most of the time. And we should initiate our treatment promptly. We adhere to the treat to target. Dito nakalagay pa remission, but I think the APLC studies are showing us that we should aim maybe more for LL-DAS because it's more feasible. And we should teach our patients to adhere to their treatment. So for them to adhere, kailangan talagang pag-usapan, no? Like recently, we had a conversation with a patient. Hindi siya adherent. So I asked the patient, how much is your monthly budget for medicine? And she said 3,000 pesos. So when we looked at all her medicines, pwede naman pala. It's just that she was buying branded medicines which were more expensive than generic medicines. So when we talked about it, we hope we can see better adherence on the next follow-up. So this is must remember. Okay, I can share the slides if you like. The EULAR had a very nice summary, but I made my own summary for it to be easier for us. Okay. So these are important things to remember. So for everyone, we should give hydroxychloroquine. Unfortunately, 55 pesos per day per tablet, no? So we have a dose of 5 milligrams per kilogram of the actual body weight. And of course, we must consider the risk for retinal toxicity. Second lang yung steroids. So this is very striking for me. If needed, give steroids. And do your best to reduce to less than 5 milligrams per day, eventually, following a tapering protocol. And if possible, withdraw. Okay? Withdraw. Siguro, I only have a handful of patients who are not on steroids. And they are those whom I gave hydroxychloroquine very early and were able to adhere. Okay. Unfortunately, for patients with nephritis, they usually flare if you withdraw the steroids. That's my observation. Okay, so when do we give immunosuppressants and biologic drugs? So when I say immunosuppressants, I'm referring to cyclophosphamide, azathioprine, mycophenolate, cyclosporine, tacrolimus, and biologic drugs, I'm referring to belimumab and anifrolumab because they are now available in the Philippines. When do we add? When we see hydroxychloroquine non-response and when we cannot reduce our steroids. Of course, if there's severe disease, then the recommendation is to give IV cyclophosphamide. And if there's refractory disease, then we give rituximab. And if you see sustained remission, then we taper our drugs. Which one do you taper first? The steroids. Okay. Now, at the right side of the screen, you have there the different organ involvements and their corresponding treatment. So I summarize this. I won't go through them one by one, but it's a nice summary, even if I say so myself. Let's look at nephritis. No, it's a big concern kasi 50% to 60% of our patients have nephritis. So kung active proliferative lupus nephritis, low dose IV cyclophosphamide. So we call that the Euro lupus protocol. Pero if they want, we can also give mycophenolate plus pulse of steroids, and then we maintain orally. We can also combine belimumab, cyclophosphamide, or mycophenolate, or calcineurin inhibitors with mycophenolate. So different options. But if the patient with lupus nephritis is at high risk for renal failure, then the IV cyclophosphamide has to be high dose. We must remember that. After renal response, let's not be very hasty in removing our immunosuppressants. We must continue for at least 3 years. So at least 3 years, no? So we give mycophenolate with or without belimumab or calcineurin inhibitors. And those who are on IV cyclophosphamide, we follow with azathioprine or mycophenolate. So inulit ko dito, sustained remission, we taper our therapy with those steroids first. And special mention are those patients with antiphospholipid antibodies syndrome. So if they have the syndrome, it means they have the autoantibodies, they have the lupus anticoagulant, and they had a thrombotic episode, then they must be on long-term vitamin K antagonist anticoagulation. And kung wala silang thrombosis but with a high risk APL profile, then they should be given low-dose aspirin. So how do we operationalize in the PGH setting? Ako lang to. You might disagree. You might have more suggestions. They will be very welcome. I think we must think of a diagnostic package so that we don't miss anything. That's my only reason, no? Sometimes nakakalimutan yung urinalysis, nakakalimutan usually yung antiphospholipid antibodies. and the lupus anticoagulant. So we must think of a complete package and maybe a minimum, no, a monitoring package so that we're more organized. I'm suggesting maganda clinical pathway algorithm. We already have in the division for seizures and for thrombocytopenia. So yung sa seizures, Dr. Joyce Cortez worked on that when she was a fellow. And yung sa thrombocytopenia, Dr. Nico Castillo worked on that. The use of immunosuppressives in patients with proven or suspected infection. We should know how to, when, how to give our immunosuppressant. So we should be working very closely with infectious disease. So I always tell the fellows and the residents, pag may infection, let's go manage with infectious disease kasi sila yung experts dito. And we should have outpatient follow-up reminders, yung evaluation for damage, screening for malignancy, cardiovascular risk, bone health, and vaccination. No? And we must continue our patient education strategies. So si Dr. Zamora Abraham is very active in the Hope for Lupus Foundation. No? The division is also working on patient education strategies. And Dr. Lorenzo is also part of the board of directors of the Hope for Lupus Foundation. Okay, so what else? We have our baby book for patients with lupus that they can use. If you want one for your patients, you can ask us. We give them away for free. And very recently, we have compiled, put together our processes in the division in the UPPGH Rheumatology Handbook. So this is hopefully for us to be better organized in managing our patients with lupus. So to summarize, we must know the definition of LLDAS, no? So the 5 criteria must be fulfilled. I hope I have shown you that damage is associated with increased risk of dying, and that the LLDAS, the lupus low disease activity state, has been shown in thousands of patients to reduce damage accrual, and that it can improve quality of life, which we want for our patients with lupus. I showed you several strategies on how to achieve LLDAS. We must diagnose early. We must manage our patients multidisciplinary, individualized, give our non-pharmacologic and pharmacologic treatments, and monitor them properly. And my last word is that we should use LLDAS as our treatment target. Let's use it. It's a good tool. So I'd like to thank you very much for listening. I hope I'm not over time. And I'd like to invite everyone because October is the Bone and Joint Month. And after this lecture, we have a webinar by Dr. Lucero on Thursday on living comfortably with osteoarthritis. So you can join us. And we have exhibits on October 14, which will be at the PGH elevator lobby. And we have lay forum and vaccination on October 19. So with that, I'd like to thank you very much for listening to this lecture. And I hope that everyone can work together to improve the lives of our patients with lupus, control disease activity, reduce damage, reduce death, and improve their quality of life. Thank you very much.